All right, hello everyone. Welcome to week 9 of the quarter. Very exciting guest speaker we have today, Dr. William Zeiger. Let's go ahead with some announcements. So first, as per the email we sent out for next quarter, we're tentatively setting our GM for Tuesday, 5 to 6 p.m., which is a change. So please try to make that adjustment if possible. And for now, we are setting it on Zoom. If anything changes, we'll let you know. Number 2, board apps is set to be released at the start of spring quarter. We'll also be recruiting. So if you think you have any friends who will be interested in joining, let them know. Third, our week 10 GM will be a social, courtesy of our awesome social chair, Crystal. We'll be also doing a quarter recap, and we have some new games and activities we'll be doing. Great.
Yes.
So, moving on to our wonderful guest speaker, we have Dr. Zeiger, and I'll pass it to RT to introduce him.
Yeah, so Dr. Zeiger is a physician scientist in the Department of Neurology, Movement Disorders Division at UCLA. He has expertise in the diagnosis and medical treatment of movement disorders, including Parkinson's disease, atypical Parkinsonism, tremors, and dystonia, among others. And his research interest includes understanding circuit dysfunction in neurological disorders such as stroke and Parkinson's disease.
Awesome. And I know we did that journal club on one of Dr. Zeiger's paper last week. So hopefully today we'll offer more insights now that he's joining us here today.
All right, great. Thanks. Should I get started then?
Yeah, that'll be wonderful. I enabled share screen.
Let me do that. Okay, can you guys see that? All right. So the email that I got suggested you guys were interested in some sort of virtual shadowing. So I have set this up mostly as a kind of clinical discussion. And I'm hoping it can be sort of a discussion. So feel free to interrupt me with questions or anything at any time. I'm happy to go into more or less detail about any of the things in the slides that interest you guys. Okay, so I've set this up sort of as a series of cases of patients that we might see in our movement disorders clinic. So in the first case is a very common referral, probably one of the most common types of patients that we get referred to see. And so this is a 61-year-old man being referred for an evaluation of tremor. So it started about a year ago. At first it was intermittent. He would notice it every once in a while, but it didn't happen all the time. But over the last year, it's become more frequent. His wife will point out when they're watching TV that his hand is shaking. He's also noticed that he's having some difficulty using that hand for fine motor tasks, like for instance, typing on the computer or buttoning his shirt. And when he goes to the gym, he occasionally feels a little off balance, but it hasn't been to the point that it's caused him to fall or anything like that. And whenever we see a patient, we do something called a review of systems, which is basically we ask them about any other symptoms that they might be having. And when we do that, he said that he has had, which started about 5 years, that he's been constipated on and off for the last 10 years. And his wife throws in that every once in a while, he will act out his dreams at night. It'll seem like he's trying to fight somebody off in his dreams. Okay, and so this is a video of what his tremor looks like. So you can see his right hand shaking there, and it happens mostly when he's sitting and resting, and it comes out a little bit more when he's walking. Okay, so let's see. Does anybody know what this is? Anybody want to venture a guess? No? Okay.
Parkinson's,
So this,
maybe?
yeah, exactly. It's Parkinson's disease. So this is the second most common neurodegenerative disorder, and is one of the most common conditions that we see in our movement disorders clinic. It's age associated. So the risk of developing Parkinson's disease goes up as you get older. But something a lot of people don't know is actually who have Parkinson's. So 25% of all Parkinson's patients will be less than 65 years old when the disease starts, and 5 to 10% will be less than 50 years old when the disease starts. Men are slightly more commonly affected than women, and most cases are what we call sporadic, meaning we don't have a particular explanation for why it has happened in that person. There are some rare hereditary forms, and these are some of the risk factors that we know about. So one of the best well documented is pesticide exposure. A history of head injuries can increase your risk for Parkinson's disease. So many of you may have seen Muhammad Ali later in his life. He had a lot of head injuries and developed Parkinson's disease. And then some of these other exposures are probably more related to pesticide exposure. There's a few epidemiological things that seem to be associated with decreased risk. So if you drink a lot of coffee, which you guys are all in college, so probably you're doing that, that's actually associated with a lower risk of Parkinson's disease. For whatever reason, people who have a history of smoking have a decreased risk of Parkinson's disease. And then there's a so there are risks in which if you have that particular mutation, you will for sure go on to get Parkinson's disease. And then there are other genes like this one here, GBA, which increases your risk for developing Parkinson's disease, but it doesn't automatically mean you will get Parkinson's disease. So,
Dr. Zeiger, before we go on, actually, there's 2 questions in the chat.
Oh, sure,
so
I
one of the
can't see
questions,
that.
okay, no worries. I can just read them out. So one question is constipation linked to Parkinson's? And then how are the two intertwined, if at all?
Yeah, great question. And we're going to get to that on the next slide. And the same thing for the next question about explanation for movement in dreams. So we're headed straight there. You guys are asking great questions. Okay, so when we think about Parkinson's disease, most people think most about tremors, but there's actually a variety of other symptoms, and we can break them down into symptoms that affect movement and symptoms that affect other parts of the body. So to diagnose Parkinson's disease, you need to have something called bradykinesia. So if you are brushing up on your Latin, you'll recognize that this means slowness of movement. Only our movements, but when they're repeated, they get smaller in amplitude. So you'll see in a bunch of these videos, we ask people to do repeated movements over and over, opening their hands or tapping their fingers or turning back and forth. And what you'll notice is that the movements are not only slow, but as they do them, they get smaller and smaller. And sometimes they actually stop moving. And that's the extreme end of bradykinesia. We call that akinesia, or lack of movement. So you need to have bradykinesia plus either a rest tremor, rigidity, which is a type of stiffness, and loss of postural reflexes, which is basically a way of saying impaired balance. Now, there's a bunch of other symptoms you might see in Parkinson's disease, including difficulties with gait, slow shuffling steps. They can have what we call bulbar symptoms, which are symptoms around the mouth and throat. So they can have slurred speech, reduced volume of speech, difficulty swallowing or drooling. They have this thing called hypomimia, which is that they don't move their faces very much. So a lot of times people think people with Parkinson's are depressed, but it's actually just that they're micrographia, which is small writing. And then a variety of other sort of symptoms of the trunk, like scoliosis, bending of the spine to one side. On the non-motor side of things, people can have difficulties with thinking. The most common is something called bradykinesia, which means slowness of thinking. Again, we're hitting this theme of slowness. And that can actually progress to dementia in some patients. Patients with Parkinson's have increased risk of depression and anxiety. They can lose their sense of smell. They can have excessive sleepiness during the day, and a symptom that I'll go into in more detail called REM behavior, which is where you're at night. You can also have constipation, hallucinations, orthostatic hypotension, which is basically where your blood pressure drops when you stand up too quickly and you can actually pass out, and urinary symptoms like having to go very urgently or even having incontinence. So here's an example of what the tremor in Parkinson's disease looks like. I mentioned to you before that it's a rest tremor, meaning that it comes out when people are just sitting there and they're not really doing anything. But when they go to do something, like for instance, write, it gets better. So you can see here on the right is a patient with essential tremor, which is a very common type of tremor that affects people when they're trying to do things, that when they try to draw a spiral, you can see the hand shaking like this. But with Parkinson's disease, it's pretty smooth. The tremor tends to go away when they're doing things. You can also see down here, they're writing. It's very small. And actually, if you look carefully, you can see that as they write, it gets smaller and smaller. And again, that's the manifestation of bradykinesia, which is that cardinal feature of Parkinson's disease. So here is a video. It's a little bit of a long video, but it's a good video, and it shows a patient with a little bit more advanced Parkinson's disease, in particular, the bradykinesia we'll appreciate here.
In the morning prior to his first dose of levodopa, his last dose having been 12 hours earlier.
I'm actually going to turn the sound off. But you can see the movements are very slow. This is what we talked about before, hypomimia, or the fact that he doesn't move his face a lot. So he's turning his hand over as fast as he can. That's as fast as he can go. And on the left side, it's even slower. And that's typical for Parkinson's disease, that one side is more affected than the other. So now he's trying to turn over his left hand, and you can see how sort of painstakingly slow it is. And the movements are really small, right? He's not going over, back and forth all the way like you or I would. And symptoms can be present in the legs as well. So here you can see it's a little bit slow in the right leg, and then the left leg is even worse. And now he's going to stand up, and we're going to do a test of his balance. And so what we do is we actually try to knock people off balance. So here they're just showing you that he's kind of stooped or hunched over. And now we're going to knock him off balance, and you can see that he has a really hard time maintaining his balance, even with just a little gentle tug on his shoulders. And now we're going to see him walk, and he has a very typical type of gait for Parkinson's disease. He's not moving his arms much. He's hunched over at the shoulders. His steps are slow and short. And it just takes him a very to get anywhere. And he's going to try to turn around here. And when he tries to turn around, what you'll see is his feet kind of get stuck to the floor there. See that? So that's that freezing that we talked about before. And it takes him about 10 or 12 steps just to turn around and then go back again. So that's a very typical presentation for more advanced Parkinson's disease. I mentioned to you before that patients can have abnormalities with their posture. That last patient was kind of hunched over forward. In extreme cases, you can have something called Pisa Syndrome, which is where patients lean over like the Leaning Tower of Pisa. And you can see this actually gets worse as the patient starts walking. And so this can be very uncomfortable for patients, obviously, and then can further increase the risk for falling. We classify this type of movement as a dystonia, which is an abnormal contraction of muscles. And what they're going to show you in a second here is that patients who have dystonia often have something called a sensory trick, where just touching the body in a certain way can make the symptoms get better. Well, I think they're just gonna touch the side of his head. Now he just reaches his head up, and he's not pulling himself up, he's just touching the side of his head, and now he can walk much more straight. And that's characteristic for a type of abnormal movement called dystonia. Okay, so I mentioned to you before that Parkinson's disease is a neurodegenerative disease, meaning it gets worse over time. And we think about the progression of symptoms of Parkinson's disease as sort of what we call a prodromal period and the sort of manifest period. So in this prodromal period, patients may not have any movement problems at all, but they can have symptoms like constipation, that REM behavior disorder where people act out their dreams, depression, daytime sleepiness, loss of smell. And these things can happen sometimes up to 20 years before any other problems with movement. And then over time, these symptoms tend to get worse and patients can develop new symptoms. So the motor symptoms start and they tend to get worse over time. And patients can also get more or more severe non-motor symptoms. So we mentioned REM sleep behavior disorder a couple times. And this is something, as I mentioned, that we often see before the motor symptoms of Parkinson's even start. And you may not realize this, but every night when you go to sleep, you go through different cycles of sleep. And one of these is called REM sleep, and that's when we dream. And during REM sleep, we're actually paralyzed. So in REM sleep, you have neurons in your brainstem that paralyze your muscles so that you actually don't act out what you're dreaming about. But in this REM sleep behavior disorder, that becomes impaired. And so this patient is fully asleep, but he's dreaming about somebody attacking him or something, and he's wildly lashing out, kicking, punching, even making noises. Now, if you take all the patients with REM sleep behavior disorder, all of them 10 or 20 years, it turns out that a very high percentage, somewhere between 80 and 90%, will actually go on to develop Parkinson's disease or a related condition, a related neurodegenerative disorder. And so it's thought that this might be a very early marker, risk marker for patients who will develop Parkinson's disease. It's that there's a high risk for injury in this disorder. The patient here is moving around so violently, he actually throws himself right off the bed. And so people can injure themselves in their sleep in this way, or they can injure their bed partners as well. So what do we know about Parkinson's disease pathology? So Parkinson's disease, when you take a look at the brains of patients with Parkinson's disease and you look carefully at neurons, you will see these structures that are shown in brown here called Lewy bodies. And you can also see this brown substance in some of the axons and dendrites of neurons, and we call these Lewy Neurites. They're named for the pathologist that found them. And in the late 90s, it was discovered that these substances are made up mostly of a protein called alpha-synuclein. And it also turns out that there are rare patients who have mutations in the gene for alpha-synuclein that causes them to develop these Lewy bodies and have Parkinson's disease. And if you examine patients who have a range of symptoms going from mild to severe, what you see is that these Lewy bodies in patients who have just early disease tend to be concentrated in the brainstem. And we think that that's why patients have problems with constipation and depression often before they develop the motor symptoms, because the alpha-synuclein pathology tends to then spread upwards. When it gets to the midbrain, it affects a part of the brain called the substantia nigra. And those are neurons that make a neurotransmitter called dopamine, which then helps to facilitate movement. So when the pathology reaches the mid and causes degeneration of neurons in the substantia nigra. Dopamine levels go down, and that's when patients start to have problems with their movement. And then as the disease progresses, symptoms progress, and the pathology progresses basically all throughout the brain. So what does alpha-synuclein actually do to neurons? Well, it does a lot of things. We know that when it's functioning normally, alpha-synuclein is enriched at presynaptic terminals and helps to facilitate the release of neurotransmitters. However, in Parkinson's disease, alpha-synuclein starts to misfold and clump up into oligomers and fibrils. So it forms these long strands that kind of clog up the cell. And that can cause a variety of problems for the cell. It can cause problems with folding of other proteins. It can cause problems of mitochondria and producing energy for cells. And basically, we think it becomes toxic to the cell at some point and leads to the degeneration of neurons. So Parkinson's disease, well, actually, it turned out we do not have any blood tests or imaging tests that can diagnose Parkinson's disease. And so our diagnosis is much the same as it was 100 years ago. And we do it based on the clinical features that a patient exhibits. And so, as I mentioned to you before, the person needs to have bradykinesia or slowness of movement, along with stiffness of the muscles, a rest tremor, or problems with balance. Then you have to rule out that these symptoms could be caused by anything else, basically. And then you feel more confident in your diagnosis if you see some of these features that are common in Parkinson's disease. Like I said before, it's usually asymmetric and starts on one side. The tremor is usually this rest tremor, which we don't see in very many other conditions. It gets worse over time, and it responds to a medicine that we'll talk about in a second called levodopa. And it tends to continue responding to levodopa for a long time. And it's a slowly progressive disease. So if patients are getting a lot worse very quickly, then that will make you think of some other conditions that we'll talk about. There are a few tests that can be done, although, again, the diagnosis is really a clinical one. There's an imaging study called a Dac Scan. This is a nuclear medicine study. So what you do is you give a radioactive substance which actually binds to dopamine transporters in the brain. And these dopamine transporters in the brain are enriched in a part of the brain called the basal ganglia. In Parkinson's disease, I mentioned before that the dopaminergic cells die off. And so those dopamine transporters go away with them. And we see less binding of this radionucleotide. And so in Parkinson's disease, you see, again, less binding. Now, this study is approved for differentiating patients with Parkinson's disease from patients who have essential tremor. But you can see patients who have Parkinson's disease who have normal scans. And you can also see patients who have essential tremor who might have an abnormal scan. And so it's really not a perfect test. There are some new tests coming out. It turns out alpha-synuclein actually deposits in other parts of the body. So if you do a skin biopsy, you can actually detect this abnormally clumped up alpha-synuclein. And so that's one way we can try to aid in the diagnosis. Alpha-synuclein also clumps up in neurons in the gut. And so we think that's probably why you get constipation in Parkinson's disease. And then finally, there's a new assay here, which is a biochemical assay. And what we can do is take cerebrospinal fluid from patients, mix it with some recombinant biochemically produced alpha-synuclein fibrils and shake it up together. And if the patient's cerebrospinal fluid has abnormal alpha-synuclein in it, then we can measure it aggregating in a test tube. And so this is a new way that's being studied to try to diagnose Parkinson's disease, and it's pretty sensitive, but is not yet FDA approved. Okay, so before I go into treatments, I'll just check and see if there's any questions here.
Yeah, Dr. Zeiger. Oh, can you see the questions in the chat?
Yeah, I was just looking at the chat now. Let's see here. Okay, there's quite a few actually. So I'll start at the top. So there must be some damage degradation to Broca's and Wernicke's area in Parkinson's patients. Broca and Wernicke's area are part of the outer part of the brain called the cortex. And those are areas that are involved in speech production and speech comprehension. In patients with Parkinson's disease, the cortex, the outer part of the brain, we think tends to be involved only in the later stages of the disease. And so patients can develop dementia in the later parts of the disease, and in patients with dementia, they can have some speech problems. But actually the dementia that patients with Parkinson's disease has tends to affect two. So these patients have a lot of trouble multitasking. They get distracted very easily. And then it also affects visual processing. So they have trouble with complex visual scenes, and they can actually have hallucinations as well. So those are the more common types of cognitive problems we see in Parkinson's disease. Let's see, I remember a patient saying they would freeze under doorways. Is there a scientific explanation or more psychological? Yeah, that's a good question. So patients with Parkinson's disease exhibit this phenomena of freezing, and they freeze most often in certain situations. It could be walking, when they have to navigate an obstacle is another place, and then going through doorways. And it probably has to do with the fact that the motor system is organized into sort of automatic behaviors and non-automatic behaviors. So an automatic behavior might be if you're out walking along in just an open space, you don't really have to think about that. Your body just kind of does it. And in Parkinson's disease, those automatic behaviors break down, and patients have to basically think about what they're doing all the time. And so the freezing that happens in doorways and getting started is probably because they have to put more mental effort into navigating those spaces. There's a really interesting phenomena called Kinesia Paradoxica, which is that patients with Parkinson's disease, sometimes in extremely stressful situations, for instance, like if they had to try to catch something that was falling really quickly in an unexpected fashion, sometimes they can move quite quickly when they do that. And it's probably because they're engaging sort of preserved motor patterns that are less affected in Parkinson's disease. So that's kind of a complicated way of answering your question. So we understand a little bit about why patients with Parkinson's freeze in those circumstances, but not completely.
I had a quick follow-up question on that, just
Sure.
because I've also heard of the phenomenon where, like, if you have a laser and you point a laser, it can help to get rid of that freeze of gait. Do we understand why that's true?
Yeah, so that's a phenomenon called cueing. So patients with Parkinson's can use visual or auditory cues to help them overcome freezing. And so it could be displaying a laser on the ground that they have to step over. For some people, just imagining something that they have to step over can work. And for others, using auditory cues like a metronome or the beat to a song can help them maintain their rhythm. And again, it's probably because it's engaging these other motor systems to help them produce a locomotion pattern, which they would otherwise be doing automatically. So you and I can just sort of walk normally without having to think about it. Parkinson's patients need some additional input, and that's either concentration and mental effort or some external input to help them maintain their walking pattern.
So does the hack that worked on the person with Pisa syndrome work in a similar way, or is that like a different mechanism than these like cues, the visual or auditory cues?
That's a good question. It's probably different. So you can see dystonia, which Pisa syndrome is a type of, in patients without Parkinson's as well. And so non-Parkinson's patients will have that, what we call sensory trick too. That is probably different in the sense that it's more of an integration of sensory information and motor information in that particular symptom of dystonia. Good question. Okay, let me go back here to the chat. So Parkinson's is mainly associated with damaged dopaminergic producing cells. Since dopamine is so widely used in the nervous system, the effects are very widespread. That's correct. Yeah. So it is mainly associated with dopaminergic producing cells, but it does affect other cells as well. So cells that produce acetylcholine and serotonin are also affected, and that's probably why patients have problems with depression and anxiety as a part of their Parkinson's disease. How is Alzheimer's and Parkinson's interlinked? That's a great question. So it's probably a lot more common than we think. So when we take a look at the brains of patients with Parkinson's disease, it's very common to see not only, for instance, alpha-synuclein pathology, but also amyloid beta pathology, which is the pathology that's seen in Alzheimer's disease. So there is a significant number of patients that can have both. And as you get older, both of these are age-associated conditions. So the likelihood of having both together goes up. Patients who have and also have amyloid beta pathology tend to have more significant cognitive impairment and dementia. And that sort of makes sense, right? Because amyloid beta pathology is associated with Alzheimer's type dementia. And the last question I see here in the chat is, what is the difference in pathology between Parkinson's and Lewy body dementia, since they're both caused by accumulation of alpha-synuclein? That's a great question. We're going to get to this a little bit more. But in dementia with Lewy bodies, patients have dementia as an early or presenting symptom, meaning they don't come in complaining of stiffness and slowness and tremor. They come in complaining of dementia and then develop the movement problems. And those patients tend to have more alpha-synuclein in the outer part of the brain, the cortex and the hippocampus. And so we think that's why they are more affected from a cognitive standpoint. They also are more likely to show amyloid beta and tau pathology in their brains. So they have more of an overlap with these other pathologies than sort of standard Parkinson's patients do. Okay, cool. Great questions. So how do we treat Parkinson's disease? As I mentioned before, there's a loss of these dopamine producing cells. And so the main way we treat it is to try to boost the amount of dopamine that the brain is making. Our sort of mainstay of treatment now for, well, since the 1960s is this drug called Levodopa. And so Levodopa gets into dopamine producing cells and it gets converted into dopamine and then gets packaged into neurotransmitters and released just like the dopamine that the body naturally produces. We have other ways of trying to boost dopamine as well. There's a couple of drugs that can prevent the breakdown of levodopa boost levels. We have drugs that are dopamine receptor agonists. So they are not dopamine, but they bind to dopamine receptors and mediate similar effects as dopamine. And then we have other drugs that work on other neurotransmitters, and I won't go into too much detail about those because we use them a lot less often. But how about levodopa in particular? So in a normal healthy person, we can sort of visualize what's going on in this way. That if we have, time here, let's say this is a 24-hour period throughout the day, and these are levodopa levels, in a normal, the amount of dopamine that your brain is making is more than enough to make sure you don't have any symptoms of Parkinson's disease or other movement problems. In Parkinson's disease, your brain isn't making as much dopamine. And so now you don't have enough dopamine in your brain and you start to have symptoms. So we give some levodopa. That's this blue trace here. And when we give levodopa, the levels of dopamine go up, symptoms improve, and then eventually the body metabolizes levodopa and the symptoms start to come back. So we can give it again. Medicine at least 3 times to keep their dopamine levels above the level needed to alleviate their symptoms. However, as Parkinson's disease advances, more neurons die off, the amount of levodopa in the brain gets lower, and the same dose of levodopa now keeps them above their sort of symptom threshold for shorter periods of time. And now we have these gaps, which we call off periods, where patients feel off, like they're frozen. And so these are really bothersome for patients, obviously, because now they have a lot of symptoms. They're not moving as well, their tremor is coming back. So we have a couple of things we could try to do to help them. One would be to increase the dose of their medicine. This will boost up their dopamine levels and it'll shorten those off periods in between doses. But it also increases the risk for adverse effects. And it turns out, as Parkinson's disease advances, the threshold at which patients get adverse effects actually goes down. And this is probably because the brain is trying to compensate for a lack of dopamine by upregulating dopamine receptors and making them more sensitive. And so in advanced Parkinson's disease, patients have this phenomena where they're off good for a little while, and then they hit this threshold where they start to have adverse effects. And the one that we really hear a lot about is something called Levodopa-Induced Dyskinesian, which are sort of excessive involuntary movements. And I'll show you a video of that in a second. As the medicine wears off, those dyskinesias go away. They feel good again for a little while, but then they hit an off period. And in really advanced patients, this can go on and on throughout the day. They fluctuate between off and on and dyskinesias all day long. And it's really challenging for patients. So here's a video of what dyskinesias look like. So this is a patient with Parkinson's disease. You can see he's actually moving around way too much. And most patients with dyskinesias actually will prefer to be like this than to be stuck and stiff and not able to move. So what do we do when patients are like this? That's when we turn to other therapies like deep brain stimulator surgery. So in this surgery, done in conjunction with our colleagues in neurosurgery, we insert electrodes into parts of the brain, usually parts of the basal ganglia, either the subthalamic nucleus or the globus pallidus internus. And what this does is it helps to smooth everything out. So it provides basically some baseline stimulation to the basal ganglia, and it helps to prevent these big fluctuations. So patients can have a lot more time feeling good without dyskinesia. Oops, wrong way. Okay, and so what does this look like? So here's a patient who had deep brain stimulator surgery. And let's see here. So right now his stimulator is on. And you can see he doesn't look too bad. He's not blinking. He's not moving his face as much as probably a normal person would. His movements are a little slow, a little small, but he can get up. He can walk pretty well. And so now when he sits back down, we're going to see what happens when we turn his stimulator off. Okay, so now they're turning off the stimulator. He has one on both sides of the brain, so they're turning off both. A fairly dramatic change. So now he starts to shake. Rest tremors come out. And they're going to have him hold up his arms. You can see now he's shaking pretty much all of his limbs, getting even a little bit worse over time. Shaking even now with holding a posture. His movements are a lot smaller, can barely lift up his feet. They're a lot slower. And let's see here. So now they're going to come and turn it back on. And you can see pretty much immediately his tremors go away and he starts to look a lot better. So this can be a really important adjunctive treatment in patients with advanced Parkinson's disease. Okay. There's a bunch of clinical trials going on for Parkinson's disease right now. All of our treatments at the current time are what we call symptomatic, meaning that they alleviate symptoms, but don't actually change or slow down the progression of the disease. And most of the things that are in clinical trials are meant to actually do that, to try to slow down the progression of the disease. And I guess for time, won't go into these in detail, but trials are ongoing to slow down the progression of disease by affecting many of the components of that neurodegenerative cascade that I showed you previously. Okay, so let me see if there's any other questions here. Yeah, so patients are very aware of their difficulties with movement. And as I mentioned before, they usually prefer being on with excessive dyskinesias to being off with bradykinesia. At what point in the disease progression would DBS be recommended? So right now we use DBS for patients with advanced Parkinson's disease who have a lot of those motor fluctuations where we can't control their symptoms well with medications. Okay, so now we're going to look at some cases that are slightly different. So this is a 68-year-old man with diabetes, hyperlipidemia, and hypertension who's referred for a 2-year history of progressive neurologic symptoms. His first problem was that he started losing his balance and falling, especially falling backwards. Then he was trying to drink things water. He complained of blurred vision, especially when he was looking down. So it became really hard for him to walk downstairs or even eat. He couldn't look down at his food very well. And he also became impulsive in his behavior, and sometimes he would laugh or cry at odd times that didn't seem to make sense. And so when you examine his eyes,
that can be easily over.
What they're doing here is they're having him look in all directions. So they're asking them to follow his finger. And you can see when they move their finger down, he has a hard time moving his eyes looking down. So they're asking him to look down, look down. So they're trying to show him where to look, and he just cannot do it. But actually, when we move his head for him, then the eyes can move down. And this is an exam finding called a vertical supernuclear gaze palsy. And if you look at his movements, so here's how he might look. He's trying to shrug his shoulders. The movements are very small. His left hand is showing some of this abnormal postures that we called dystonia before. It's moving very slowly. So the right hand, the movements are a little small. They're getting smaller as he goes. So that's bradykinesia. Left hand, let me show that. See here, the left hand is worse, very small movements. He has a hard time with that. And let me see here, I want to show you his walking if I can. Yes, okay, so they're going to ask him to stand up from the chair. He's got to use his arms to get up, and you can see he looks really off balance, like he can barely get out of this chair. He's about to fall backwards. He's really checking to make sure he's stable before he stands up. And differently than our first patient. So his steps are fairly normal size, but they're kind of his feet are wide apart, and he's walking kind of very stiffly. He's not swinging his arms at all. He kind of looks almost like stiff as a board. And now they're going to do that pull test where they pull him backwards. And you remember our Parkinson patients took a bunch of steps backwards and lost their balance. So when they pull back on him, he doesn't even take steps backwards. He just falls right into the examiner. So this is a disease called progressive supernuclear palsy. And this is most common type of atypical Parkinsonian disorders. So these are a group of disorders that share features of Parkinson's disease, but are atypical in one way or another. And they tend to not respond to medication much. Much more rapidly to the point that patients with these disorders tend to pass away in an average of 8 to 10 years. So these are very aggressive diseases. The pathology can be related to a number of proteins. In the case of progressive supernuclear palsy, it's misfolded tau proteins, as opposed to synuclein, which we saw in Parkinson's disease. And then you may also hear about amyloid, as we mentioned before, in Alzheimer's disease, or another protein called TDP-43, which can be seen in Lou Gehrig's or ALS, or a frontotemporal dementia, another type of neurodegenerative disease. So we'll quickly go through a few of these. All these are going to start pretty similarly. So this is now a 78-year-old woman who has a 2-year history of progressive neurologic symptoms. She started with slowed movements and losing her balance. So sounds like it could be Parkinson's disease. Then her left hand began to twist to the point that it became nearly unusable, and at times it would start to move seemingly out of her control. She developed intermittent, jerky, involuntary movements, so not quite a tremor, and then a lot of difficulty finding words to the point that she began speaking less and less and hardly at all.
Would you describe for us what the feeling you have in the right hand? What does it feel?
So
CBD is describing the alien hand syndrome.
she's describing that
She also has
her hand will
asymmetric
do things
apraxia and characteristic
on
cortical
her own.
myoclonus.
Let me turn off the sound, sorry. So she's describing that her hand will just sort of move on its own. And then we'll take a look at her hand movements here. So he's asking her to do a thumbs up. She can kind of do that. And now show 2 fingers. And she can do it with her left hand, sort of, although it's not quite right. And with her right hand, she just can't seem to do it at all. So she's even going to try to use her left hand to help her out. And now they're trying to show her a different hand thing, and she can kind of do it with the left hand, but again, not very smooth, not quite right. And she cannot do it with her right hand at all. And she also has these like for the hand and arm kind of do these jerky movements. So it looks very different than the tremor that we saw in Parkinson's disease. And so now I'll show you one other video, a different patient, but this is sort of the movement that she was describing, but in the leg, where the leg is just sort of lifting off the ground on its own. The patient's not trying to do that. In fact, they're not even aware that it's happening. And this is something that we call an alien limb phenomena, because it's like an alien has taken control of part of your body. And so this is a condition called cortico-basal degeneration. And it is also usually a tauopathy, but also can be seen with amyloid pathology. And asymmetric, like one arm becomes basically totally useless. It can have a lot of dystonia or cramping of postures. What they were showing in that video is something called apraxia, where they cannot do previously learned motor tasks like showing different hand postures or anything like that. And then they get a lot of cognitive problems as well. And then the last case here that I'll present to you, 57-year-old woman, again, 2 years of progressive neurologic symptoms. In this case, her problem started with urinary frequency, and then that progressed to incontinence. and she'd actually has now passed out several times after standing up from bed in the morning. After that started, she developed stiffness in her limbs, problems with dexterity in both hands. She developed imbalance and some falls. And she had one episode of stridor, which is a wheezing problem where your vocal cords actually pinch together and you can't pass air through your trachea. And that happened in the middle of the night, and she had to go to emergency room to get treated. And so here's her, a picture of her. And so this patient, you can see, has a tracheostomy, which is sometimes needed because of that stridor problem. The feet here are kind of this purplish blue color. This is because her autonomic nervous system is not working well to regulate temperature in her limbs. That's also what leads to problems with passing out and problems with maintaining urinary continence. She has a little bit of this, again, dystonia that we talked about in several of our cases. And she has this sort of incoordinate, she has a difficult time reaching the finger accurately of the examiner. And let's see, I think that's all I want to show there. So this is a condition called multiple systems atrophy. And this is another synucleinopathy, as opposed to the tauopathy that we discussed about in the other cases. And in these patients, what you see are a lot of problems with autonomic failure, and that stridor is a very problematic symptom. And so again, these are all atypical Parkinsonian disorders. They share features of Parkinson's disease, but then they have these, what we call red flag symptoms that are different than what would typically be seen in Parkinson's disease. And we don't have a way to differentiate these in the clinic other than going by the signs and symptoms that our patients show us. And so this is sort of a graphic showing that here. When we see a patient and we're evaluating them for Parkinson's disease, we have to decide, do they have the criteria for Parkinson's disease? And are there any red flags or symptoms that would be suggestive of these atypical Parkinsonian disorders? And sometimes this balance shifts over time, in the sense that they may present with mostly symptoms of Parkinson's disease, but over time you start to notice more and more red flags, and then eventually go on to make or change your diagnosis to an atypical Parkinsonian disorder. So I think I'll stop there because we're almost at 6, and see if there's any last questions. No?
I guess I just have one last question. So, because I know you mentioned like RBD being like a really big indicator that someone's going to get Parkinson's. So I was just wondering, do you guys like do movement disorders doctors like usually collaborate with sleep disorder doctors in those cases?
Yeah, frequently if a sleep doctor diagnoses REM behavior disorder, they will refer them to us to see if maybe there's some subtle signs of Parkinson's disease. And in fact, right now there's a big trial going on, which is a trial that is combining sleep experts and movement experts to take a cohort of patients who have REM sleep behavior disorder, follow them, see what happens, but also try to enroll them in trials to give them medicines that might reduce their risk for developing Parkinson's disease. So I think that's going to be a really interesting group of patients to see what happens.
Amazing. Any last questions? Just so we respect Dr. Zeiger's time. All right, I know we definitely had a lot in the middle of the session.
Yeah.
But I personally thought this was such a really comprehensive virtual shadowing session. So thank you so much for preparing all 4 clinic cases for us to go over.
Of course, happy to do it. And please, if you guys have questions later about the, Parkinson's or careers in neurology or neuroscience, don't hesitate to send me an email.
Wonderful. Thank you so much, Dr. Zeiger.
All right. Take care.
Take care.
Bye-bye.